The cervical viscera are composed of 3 layers named after their primary function. The most superficial layer is the endocrine layer, which contains the thyroid and parathyroid glands. Then there's the respiratory layer, which contains the larynx and trachea. And finally, the deepest layer is the alimentary layer, which contains the pharynx and esophagus. Focusing on the respiratory layer of cervical viscera, this contains the larynx and trachea that routes air to the lungs and gives everyone their own unique voice. And saying that just made me aware of my own voice in this video recording. So let's start with the larynx, which is responsible for voice production and maintaining a patent airway. The larynx is located in the anterior neck at the level of the bodies of C3-C6 vertebrae and connects the inferior part of the pharynx with the trachea. It also contains the vocal cords or vocal folds, so it's responsible for voice production. Now, the larynx has a skeleton, which is hardly a skeleton. Rather, it's formed of 9 cartilages: thyroid, cricoid, and epiglottic cartilages, which are single and arytenoid, corniculate, and cuneiform cartilages, which come in pairs of 2. The thyroid cartilage is the largest cartilage, and its superior border lies opposite the C4 vertebra. It's formed by 2 plate-like laminae, which unite in the middle to form the laryngeal prominence, also known as the Adam's apple, which is well marked in males and less visible in females. Superior to this prominence, the laminae diverge to form a V-shaped notch, called the superior thyroid notch, and in the middle of the inferior border of the cartilage, a shallow indentation can be found called the inferior thyroid notch. The posterior border of each lamina projects superiorly as the superior horn and inferiorly as the inferior horn. The superior border and the superior horns attach to the hyoid bone through a membrane called the thyrohyoid membrane. This membrane has a thick median part, which represents the median thyrohyoid ligament, and 2 lateral parts, which represent the lateral thyrohyoid ligaments. The inferior horns articulate with the lateral surfaces of the cricoid cartilage and form the cricothyroid joints, which allow rotation and gliding of the thyroid cartilage, resulting in changes in the length of the vocal folds. The cricoid cartilage is shaped like a ring with a thin interior band and a broad posterior band, and it's the only complete ring of cartilage to encircle any part of the airway. Its posterior part is the lamina of the cricoid, and the anterior part is the arch, which attaches superiorly to the inferior margin of the thyroid cartilage through the median cricothyroid ligament, and inferiorly to the first tracheal ring through the cricotracheal ligament. The cricoid cartilage is also a key landmark in the neck, because it's situated at the level of the C6 vertebra. This is where the carotid artery can be compressed against the C6 vertebra, and also where the larynx and trachea join, where the pharynx joins the esophagus, and the point where the recurrent laryngeal nerve enters the larynx. The arytenoid cartilages are paired, pyramidal-shaped cartilages that articulate with the lateral parts of the superior border of the cricoid cartilage lamina. Each arytenoid cartilage has an apex superiorly, where the corniculate cartilage can be found. Connecting the arytenoid and epiglottic cartilages, there is a thin submucosal sheet of connective tissue called the quadrangular membrane. This membrane has a free superior margin that forms the aryepiglottic ligament. This ligament is covered by mucosa to form the aryepiglottic fold. Posterior to the aryepiglottic folds, there are small nodules that represent the corniculate and cuneiform cartilages. The quadrangular membrane also has a free inferior margin that forms the vestibular ligament, which is covered by mucosa, forming the vestibular fold. Now back to the arytenoid cartilage. Its apex attaches to this aryepiglottic fold, or mucosal-covered aryepiglottic ligament, which is the superior aspect of the quadrangular membrane. The arytenoid cartilage also has a vocal process anteriorly that provides the posterior attachment for the vocal ligament, as well as a large muscular process that projects laterally from its base and acts as a lever to which the posterior and lateral cricoarytenoid muscles are attached. Between the bases of the arytenoid cartilages and the superlateral surfaces of the lamina of the cricoid cartilage, there are the cricoarytenoid joints, which allow some important movements in approximating, tensing, and relaxing the vocal cords by allowing the arytenoid cartilages to slide towards or away from one another, to tilt anteriorly and posteriorly, and to rotate. Now, the elastic vocal ligaments form the submucosal skeleton of the vocal folds and extend from the junction of the laminae of the thyroid cartilage anteriorly to the vocal process of the arytenoid cartilage posteriorly. The vocal ligaments are the thickened free superior border of the conus elasticus. The other component of the conus elasticus is the lateral cricothyroid ligament, which extends laterally between the vocal folds and the superior border of the cricoid. The conus elasticus blends anteriorly with the median cricothyroid ligament, and along with the overlying mucosa, it closes the tracheal inlet except for the central zone called the rima glottidis, which is the opening between the vocal folds. The epiglottic cartilage lies posterior to the root of the tongue and the hyoid bone, and anterior to the laryngeal inlet, and it forms the superior part of the anterior wall and the superior margin of the inlet. It consists of elastic cartilage and gives flexibility to the epiglottis, which is a heart-shaped cartilage covered with mucous membrane. It also functions as a valve, closing off the superior opening of the larynx during swallowing. Now, the inferior end of the epiglottic cartilage, called the stalk of the epiglottis, is attached by the thyroepiglottic ligament to the angle formed by the thyroid laminae. Time for a break. Can you identify the cartilages of the larynx? Now, the laryngeal cavity extends from the laryngeal inlet, through which it communicates with the laryngopharynx, to the level of the inferior border of the cricoid cartilage, where it continues with the tracheal cavity. The laryngeal cavity is divided into three regions. The laryngeal vestibule, which is located between the laryngeal inlet and the vestibular folds. The middle part, which is a central cavity between the vestibular and vocal folds. And the infraglottic cavity, which is located between the vocal folds and the inferior border of the cricoid cartilage, where it continues with the tracheal lumen. In the middle part of the laryngeal cavity, there are two recesses called the laryngeal ventricles that extend laterally between the vestibular and vocal folds. And inside each ventricle, there's an outpouching called the laryngeal saccule, which is lined with mucosal glands. Now, the vocal folds are the sharp folds of mucous membrane, overlying and incorporating the thyroarytenoid muscles and the vocal ligaments, which represent the medial free edge of the conus elasticus. Each of the vocal folds also contains the vocalis muscle, which are slender muscle slips medial to the thyroarytenoid muscles, lateral to the vocal ligament, and contain exceptionally fine fibers. These folds produce audible vibrations when their free margins are closely opposed during phonation and air pushed out of our lungs. When these folds are completely closed, this prevents entry of the air into the lungs. Finally, the vocal folds, together with the vocal processes and the rima glottidis, form the glottis. Now, the shape of the rima glottidis varies according to the position of the vocal folds. So, during normal breathing, the rima is narrow and wedge-shaped. But during forced respiration, it's wide and trapezoidal. Also, during phonation, the rima is slit-like. The pitch of the voice is changed by variations in the tension and length of the vocal folds, in the width of the rima glottis, and in the intensity of the expiratory effort. This is the reason why the male voice typically becomes lower pitch after puberty, because the vocal folds increase in length. Now, the vestibular folds extend between the thyroid and arytenoid cartilages, which mostly play a protective role, and don't really participate in sound production, so they are termed the false vocal cords. They consist of two thick folds of mucous membrane, enclosing the vestibular ligaments. Let's take another break and see if you can identify the main structures in the laryngeal cavity. Moving on to the laryngeal muscles, which are divided in two groups: the extrinsic muscles and intrinsic muscles. The extrinsic muscles move the larynx as a whole and are represented by the infrahyoid muscles, which depress the hyoid and larynx, and the suprahyoid muscles, along with the stylopharyngeus, which elevate the hyoid and larynx. On the other hand, the intrinsic muscles move different laryngeal components to alter the length and shape of the vocal cords and the rima glottidis. According to their main function, they are divided into functional groups, such as abductors and adductors, sphincters, tensors, and relaxers. First, the abductor and adductor muscles move the vocal folds to open and close the rima glottidis. Now, the main adductors are the cricoarytenoid muscles, which arise from the arch of cricoid cartilage and insert on the vocal process of arytenoid cartilage. The lateral cricoarytenoid muscles pull the muscular processes anteriorly and rotate the arytenoid cartilages. The transverse and oblique arytenoid muscles arise from one arytenoid cartilage and insert to the contralateral arytenoid cartilage. This pulls the arytenoid cartilages together. The combined action of the adductors causes the vocal folds to come together, and when air is pushed past the vocal folds, that causes vibrations and phonation. When the transverse arytenoid muscles don't act, the arytenoid cartilages remain separated, and this allows us to whisper, the correct answer to the classmate sitting next to us in class. These adductors also act as a reflexive sphincter to bring the aryepiglottic folds together in the presence of liquid or particles approaching the laryngeal vestibule. Now that's something to be grateful for every time we swim. The only abductors of vocal folds are the posterior cricoarytenoid muscles, which arise from the posterior surface of the cricoid cartilage lamina and insert on the vocal process of arytenoid cartilage and rotate the vocal processes laterally to widen the rima glottidis. Moving on, the main tensor muscles of the larynx are the cricothyroid muscles, which arise from the anterolateral part and insert into the inferior margin and inferior horn of the thyroid cartilage. They tilt or pull the prominence or angle of the thyroid cartilage anteriorly and inferiorly toward the arch of the cricoid cartilage, which increases the distance between the thyroid prominence and the arytenoid cartilages. This makes the vocal ligaments elongate and tighten, raising the pitch of voice. The main relaxers of the larynx are the thyroarytenoid muscles, which arise from the lower half of the posterior aspect of the thyroid cartilage and cricothyroid ligament and insert onto the anterolateral arytenoid surface. They relax the vocal ligaments by pulling the arytenoid cartilages anteriorly towards the thyroid angle, and thus lowering the pitch of the voice. Finally, there's a muscle which acts as both a tensor and relaxer of the larynx, and that's the vocalis muscle, which is medial to the thyroarytenoid muscles and lateral to the vocal ligaments within the vocal folds. The vocalis muscle arises from the lateral surface of the vocal process of the arytenoid cartilage and inserts on the ipsilateral vocal ligament and acts during animated speech and singing by tensing and relaxing the vocal ligaments and folds. All the intrinsic muscles of the larynx are innervated by branches of the vagus nerve. All but one are innervated by the recurrent laryngeal nerve via its terminal branch, except for the cricothyroid muscles, which are innervated by the external laryngeal nerve. Let's take a break and try to identify the intrinsic and extrinsic laryngeal muscles. Now, the larynx is supplied by the superior and inferior laryngeal arteries, which are branches from the superior and inferior thyroid arteries, respectively. The superior laryngeal artery runs through the thyrohyoid membrane, along with the internal branch of the superior laryngeal nerve, and divides to supply the internal surface of the larynx. The inferior laryngeal artery runs with the inferior laryngeal nerve and supplies the mucous membrane and muscles in the inferior part of the larynx. The veins of the larynx are represented by the superior and inferior laryngeal veins, which accompany the laryngeal arteries. The superior laryngeal vein joins the superior thyroid vein, and through it drains into the internal jugular vein. The inferior laryngeal vein joins the inferior thyroid vein, or the venous plexus, and drains into the left brachiocephalic vein. The larynx is innervated by the superior and inferior laryngeal nerves, which are branches from the vagus nerve. The superior laryngeal nerve arises from the inferior vagal ganglion at the superior end of the carotid triangle. Inside the carotid sheath, The nerve divides into two terminal branches, the internal laryngeal nerve and the external laryngeal nerve. The internal laryngeal nerve runs with the superior laryngeal artery through the thyrohyoid membrane and supplies sensory fibers to the laryngeal mucous membrane of the laryngeal vestibule and middle laryngeal cavity, as well as the superior surface of the vocal folds. The external laryngeal nerve descends posterior to the sternothyroid muscle, along with the superior thyroid artery, then pierces the muscle and continues to supply the cricothyroid muscle. The internal laryngeal nerve gives sensory fibers where the external gives motor fibers. To remember that, think about driving a motorcycle outside. So external is for motor. The inferior laryngeal nerve is a continuation of the recurrent laryngeal nerve after its course in or near the tracheoesophageal groove. The inferior laryngeal nerve enters the larynx by passing deep to the inferior border of the inferior pharyngeal constrictor and medial to the lamina of the thyroid cartilage. Its main role is to provide motor innervation to the larynx and sensory innervation to the mucosa of the infraglottic cavity. One final structure in the respiratory layer is the trachea. The trachea starts at the inferior end of the larynx at the level of C6 vertebra, and it ends at the level of the sternal angle or the T4-T5 intervertebral disc, where it divides into the right and left main bronchi. The trachea is a fibrocartilaginous tube, supported by incomplete cartilaginous rings called tracheal cartilages that keep the trachea patent. These cartilages are deficient posteriorly, where the trachea is adjacent to the esophagus. The posterior gaps in the tracheal rings are spanned by the trachealis muscle, which connects the ends of the rings, giving a flat aspect to the posterior wall of the trachea. Okay, as a quick recap. The larynx is located in the interior neck at the level of the bodies of C3 to C6 vertebrae, and connects the inferior part of the pharynx with the trachea. The laryngeal skeleton is formed of 9 cartilages: thyroid, cricoid, and epiglottic cartilages, which are single and arytenoid, craniculate, and cuneiform cartilages which come in pairs of 2. The laryngeal cavity extends from the laryngeal inlet through which it communicates with the laryngopharynx to the level of the inferior border of the cricoid cartilage, where it continues with the tracheal cavity. The laryngeal cavity is divided into 3 regions: the laryngeal vestibule, which is located between the laryngeal inlet and the vestibular folds, the middle part, which is the central cavity between the vestibular and vocal folds, and the infraglottic cavity, which is located between the vocal folds and the inferior border of the cricoid cartilage, where it continues with the tracheal lumen. The laryngeal muscles are divided in 2 groups: extrinsic muscles and intrinsic muscles. The extrinsic muscles move the larynx as a whole and are represented by the infrahyoid muscles, which depress the hyoid and larynx, and the suprahyoid muscles, which elevate the hyoid and larynx. The intrinsic muscles move different laryngeal components, and according to their main function, they are divided into functional groups which alter the vocal folds to produce and change phonation and pitch. This area is mainly supplied by the superior and inferior laryngeal arteries, and its main innervation is from the superior and inferior laryngeal nerves. Finally, the trachea is a tube formed by incomplete tracheal cartilages, which start at the inferior end of the larynx at the level of C6 vertebra and ends at the level of the sternal angle or the T4-T5 intervertebral disc, which divides into the right and left main bronchi.
Whenever we go to the doctor's office with what we think is a respiratory infection, they will often feel for nodes in the neck. What they are feeling for are the lymph nodes in our neck, which drain the head and neck and become enlarged when there's an infection. Enlarged lymph nodes can also indicate other clinical conditions, such as cancers. So by understanding the anatomy of the lymph nodes in the neck and their drainage, this can help with clinical diagnosis. So, the lymphatics of the head and neck can be divided into 2 groups: a superficial group of nodes and a vertical group of deep lymph nodes. So, the superficial lymph nodes receive lymph from the scalp, face, and neck. There are 8 groups of superficial lymph nodes which extend from underneath the chin to the posterior aspect of the head, and they are represented by the occipital, mastoid, preauricular, parotid, submental, submandibular, buccal, and superficial cervical lymph nodes. The occipital lymph nodes are located in the back of the head at the lateral border of the trapezius muscle and collect lymph from the occipital area of the scalp. The mastoid lymph nodes are also called retroauricular lymph nodes, and they're located posterior to the ear. Specifically, they lie on the insertion of the SCM into the mastoid process, and they collect lymph from the posterior neck, upper ear, and lateral scalp. The preauricular lymph nodes are located anterior to the auricle of the ear and collect lymph from the superficial areas of the face and temporal region. The parotid lymph nodes are located superficial to the parotid gland and collect lymph from the lateral side of the face and scalp. The submental lymph nodes are located in the submental triangle superficial to the mylohyoid muscle and collect lymph from the chin and lower lip. The submandibular lymph nodes are located below the mandible in the submandibular triangle and collect lymph from the face inferior to the eye and from the mouth. The buccal lymph nodes collect lymph from the nose and cheek. The superficial cervical lymph nodes are located close to the external and anterior jugular veins and collect lymph from the superficial surfaces of the anterior neck. These superficial groups of lymph nodes all drain into the deep group of lymph nodes, which are organized into vertical chains that are located close to the internal jugular veins, mostly under the sternocleidomastoid muscles. The deep cervical lymph nodes include many lymph nodes such as the prelaryngeal, pretracheal, paratracheal, retropharyngeal, jugulodigastric or tonsillar, and jugulo-omohyoid. The jugulodigastric nodes are part of the superior deep cervical nodes, and the jugulo-omohyoid node is part of the inferior deep cervical nodes. The deep cervical nodes eventually drain to the left venous angle via the thoracic duct, or the right venous angle via the right lymphatic duct. Finally, let's take a quick look at the lymphatic drainage of the cervical viscera. The lymphatic vessels of the thyroid gland drain initially into the prelaryngeal, pretracheal, and paratracheal lymph nodes. Then, the prelaryngeal nodes drain into the superior deep cervical lymph nodes, and the pretracheal and paratracheal nodes drain into the inferior deep cervical lymph nodes. The lymphatic vessels of the parathyroid glands drain with those of the thyroid gland into the paratracheal lymph nodes and the deep cervical lymph nodes. The lymphatic vessels of the larynx are divided into two groups. Superior to the vocal folds, lymphatic vessels drain into the superior deep cervical lymph nodes, and inferior to the vocal folds, lymph drains into the pretracheal or paratracheal lymph nodes and then into the inferior deep cervical lymph nodes. The lymphatic vessels of the cervical esophagus drain into the paratracheal lymph nodes and the inferior deep cervical lymph nodes. All right, before we hit the recap, let's take a break and try to identify the superficial and the deep cervical lymph nodes. All right, as a quick recap, the lymphatics of the head and neck are divided into two groups, a superficial group of lymph nodes and a vertical group of deep lymph nodes. The superficial lymph nodes extend from underneath the chin to the posterior aspect of the head, and these are the occipital, mastoid, preauricular, parotid, submental, submandibular, buccal, and superficial cervical lymph nodes to drain the scalp, face, and superficial structures of the neck. The deep cervical lymph nodes receive lymph from the superficial group of nodes and are organized into a vertical chain along the internal jugular vein.
The cervical viscera are composed of 3 layers based on their main functions. The most superficial layer is the endocrine layer, which contains the thyroid and parathyroid glands. Then there's the respiratory layer, which contains the larynx and the trachea. And finally, the deepest layer is the alimentary layer, which contains the pharynx and the esophagus. So let's start with the pharynx, which also has a respiratory function because it conducts air to the larynx, from where it passes through the trachea and into the lungs. The pharynx extends from the cranial base to the inferior border of the cricoid cartilage anteriorly and the inferior border of the C6 vertebra posteriorly. It's located posterior to the nasal and oral cavities, and it extends inferiorly past the larynx, where it continues with the esophagus. Now, the pharyngeal wall consists of 3 layers. The bucopharyngeal fascia is the most external layer, covering the pharynx, and inferiorly, it's continuous with the pretracheal fascia. Then there is a muscular layer, which has an outer circular part and an inner longitudinal part, and the innermost mucous membrane, which has a thick submucosa that contributes to the pharyngobasilar fascia. Moreover, the posterior wall of the pharynx lies against the prevertebral layer of the deep cervical fascia. The interior of the pharynx is divided into 3 parts. The nasopharynx, which is located posterior to the nose and superior to the soft palate, the oropharynx, which is located posterior to the mouth, and the laryngopharynx, which is located posterior to the larynx. The nasopharynx is the posterior extension of the nasal cavities and communicates with the nose through 2 paired openings called the choanae, which are separated by the posterior end of the nasal septum. The roof and the posterior wall of the pharynx form a continuous surface that lies inferior to the body of the sphenoid bone and the occipital bone. On the lateral wall of the nasopharynx, there's the opening of the pharyngotympanic tube, also called the auditory tube or the eustachian tube, which connects the nasopharynx to the tympanic cavity. Superior to this opening, there is the cartilage of the pharyngotympanic tube, called torus tubarius, and inferior to this opening, there's an elevation of mucosa as it overlies the levator veli palatini muscle. From the medial end of the pharyngotympanic tube, a vertical fold of mucous membrane extends inferiorly, called the sapingopharyngeal fold, which covers the sapingopharyngeus muscle. This muscle raises the pharynx during swallowing, while at the same time opening the pharyngeal orifice of the pharyngotympanic tube. This last action helps equalize the pressure in the pharynx to that of the auditory canal. Finally, posterior to the torus tubarius and the sapingopharyngeal fold, there is the pharyngeal recess, which is a slit-like projection of the pharynx that extends laterally and posteriorly. Now, the pharynx contains abundant lymphoid tissue. In some regions, the lymphoid tissue is aggregated and forms masses called tonsils. Pharyngeal tonsils, called adenoids when enlarged, can be found in the mucous membrane of the roof and posterior wall of the nasopharynx, just above the pharyngeal recess. Additionally, there are tonsils located in the submucosa near the orifice of the pharyngotympanic tube, called tubal tonsils. Let's take a quick break and try to identify the nasopharynx as well as the structures contained by it. The second part, or the oropharynx, lies posterior to the oral cavity, which is bounded superiorly by the soft palate, inferiorly by the base of the tongue, and laterally by the palatoglossal and palatopharyngeal arches. It extends from its superior border of the soft palate to the superior border of the epiglottis. Between the base of the tongue and the epiglottis, there is a midline fold of mucosa called the median glossoepiglottic fold. And between the base of the tongue and the lateral border of the epiglottis, there is another fold of mucosa called the lateral glossoepiglottic fold. Between these 2 folds, there is a depression called the epiglottic vallecula, which serves a role in temporarily storing the saliva so as not to trigger the swallowing reflex. Now, the oral cavity and the oropharynx are separated by a line formed by the palatoglossal arch. Posterior to the palatoglossal arch, there's a palatopharyngeal arch, which descends along the lateral wall of the oropharynx. These are the two folds you can see in the back of the mouth when someone is opening up to say, ah. Between these two arches, there is a space called the tonsillar sinus, where the palatine tonsils can be found. The palatine tonsil is supplied by a branch of the facial artery called the tonsillar artery, which passes through the superior pharyngeal constrictor muscle and enters the inferior pole of the tonsil. The tonsil is drained by the external palatine vein, which descends from the soft palate and passes close to the lateral surface of the tonsil before it enters the pharyngeal venous plexus. Now, the palatine tonsils, along with the pharyngeal and tubal tonsils located in the nasopharynx, in addition to the lingual tonsil located in the posterior part of the tongue, form an incomplete circular band of lymphoid tissue around the superior part of the pharynx called the pharyngeal lymphatic ring, or the Waldeyer ring. The antero-inferior part of the ring is formed by the lingual tonsil, the lateral parts of the ring are formed by the palatine and tubal tonsils, and the posterior and superior parts are formed by the pharyngeal tonsil. Let's take a quick break and try to identify the oropharynx as well as the tonsils that form the pharyngeal lymphatic ring. Finally, the laryngopharynx is posterior to the larynx and extends from the superior border of the epiglottis and the pharyngo-epiglottic folds to the inferior border of the cricoid cartilage, where it narrows and eventually becomes the esophagus. Now, the posterior and lateral walls of the laryngopharynx are formed by the middle and inferior pharyngeal constrictor muscles, and internally the wall is formed by the palatopharyngeus and stylopharyngeus muscles. The laryngopharynx communicates with the larynx via the laryngeal inlet on its anterior wall. On each side of the laryngeal inlet, there is a small depression called the piriform fossa, or recess, which is covered by mucosa and is separated from the laryngeal inlet by the airy epiglottic fold. The piriform fossa is bounded laterally by the medial surfaces of the thyroid cartilage and the thyrohyoid membrane, and medially by the lamina of the cricoid cartilage, both covered in mucous membrane. Deep to the mucous membrane of the piriform fossa, there are branches of the internal laryngeal and recurrent laryngeal nerves, which are exposed to injury if a foreign body lodges in the fossa. Let's take another break and see if you can identify the laryngopharynx as well as the structures contained by it. Now let's move on and take a look at the pharyngeal muscles. The pharynx has two layers of muscles, an external circular layer composed of three muscles, superior, middle, and inferior pharyngeal constrictors, and an internal longitudinal layer composed also of three muscles, palatopharyngeus, stylopharyngeus, and salpingopharyngeus. Now let's take a big gulp and try to digest these muscles that help us speak and swallow. So first, let's start with the external layer, which has three muscles: the superior pharyngeal constrictor, the middle pharyngeal constrictor, and the inferior pharyngeal constrictor, all of which come in mirrored pairs. Although these are skeletal muscles, they contract involuntarily, in sequence from the superior to the inferior constrictor during swallowing to help, constrict the wall of the pharynx. So far, so good. The pharyngeal constrictors have a strong internal fascial lining called the pharyngobasilar fascia, and a thin external fascial lining called the buccopharyngeal fascia, which, as we mentioned before, blends inferiorly with the pretracheal layer of deep cervical fascia. The superior pharyngeal constrictor originates on the pterygomandibular raphe and the adjacent parts of the medial pterygoid plate and mandible. The middle pharyngeal constrictor arises from the stylohyoid ligament and the greater and lesser horns of hyoid bone, and its inferior fibers lie deep to the inferior constrictor muscle. Finally, the inferior pharyngeal constrictor arises from the oblique line of the thyroid cartilage and from the side of the cricoid cartilage. The most inferior fiber of the inferior constrictor is called the cricopharyngeal part, which is continuous with the esophagus. Now, all of the pharyngeal constrictors curve towards the back and insert on a fibrous line called the pharyngeal raphe. All three constrictors are innervated by the pharyngeal branch of the vagus nerve and the pharyngeal plexus of nerves, which has contributions from the vagus and glossopharyngeal nerves, as well as the sympathetic nerves. Now let's switch gears and take a look to the internal layer, which is also composed of three muscles: palatopharyngeus, stylopharyngeus, and salpingopharyngeus. The palatopharyngeus muscle arises from the hard palate and the palatine aponeurosis, and inserts on the thyroid cartilage and on the pharyngeal wall, or simply from the palate to the pharynx, hence palatopharyngeus. The salpingopharyngeus muscle arises from the cartilaginous part of the pharyngotympanic tube and blends with the palatopharyngeus muscle to the same insertion. The stylopharyngeus arises from the styloid process of the temporal bone and attaches to the thyroid cartilage along with the palatopharyngeus. Yet again, from the styroid to the pharynx, hence the name stylopharyngeus. Easy, right? The palatopharyngeus and salpingopharyngeus muscles are innervated by the pharyngeal branch of vagus nerve and by the pharyngeal plexus, while stylopharyngeus is innervated by the glossopharyngeal nerve or cranial nerve 9. All these muscles elevate the larynx and shorten the pharynx during swallowing and speaking. Now, there are also a few other muscles that can be seen from a posterior view of the pharynx. First up, the sternocleidomastoid. Here we can see where it inserts into the mastoid process. Medial to that, there's the posterior belly of the digastric muscle, which also attaches on the mastoid process of the temporal bone. Finally, there's the stylohyoid muscle, which in a similar fashion to the stylopharyngeus muscle originates on the styloid process. Before we move on, let's take a break and see if you can identify the pharyngeal muscles. Now, speaking of the posterior pharynx, there are a number of vessels we can visualize and identify. First, there are the common carotid arteries and their branching into the internal and external carotid arteries. Branches of the external carotid artery supply the pharynx. Lateral to the internal carotid artery, there's the internal jugular vein as it travels through the internal jugular foramen. Finally, lower down, we can also visualize the inferior thyroid artery after it branches from the thyrocervical trunk to supply the thyroid gland, as well as nearby structures such as the pharynx. To go along with the vessels of the posterior pharynx, there are also numerous nerves running through and supplying this area that we can identify. First off, the pharynx is innervated by the pharyngeal plexus, located on the posterolateral aspect of the pharynx, which has motor, sensory, and sympathetic fibers. The motor fibers are derived from the vagus nerve, or cranial nerve 10, via its pharyngeal branches, and they supply all muscles of the pharynx and soft palate, except for the stylopharyngeus and the tensor veli palatini muscle, which is a muscle that tenses the soft palate, thereby helping to elevate it. The sensory fibers are derived from the glossopharyngeal nerve, or cranial nerve 9, and they are distributed to all three parts of the pharynx. Now, there are three nerves that exit the jugular foramen medial to the internal jugular vein, namely the vagus nerve, the glossopharyngeal nerve, as well as the spinal accessory nerve. Remember, the vagus nerve gives rise to a pharyngeal branch, as well as the superior laryngeal nerve and its subsequent terminal branches, called the internal branch and external branch. Also remember, the vagus nerve branches into the recurrent laryngeal nerves in the inferior part of the neck, and we can see these recurrent laryngeal nerves ascending back up towards the larynx on either side of the esophagus in the tracheo-esophageal groove. We can also identify the hypoglossal nerve in the submandibular triangle passing laterally to the carotids but medial to the internal jugular vein. Then, just posterior and medial to the carotid arteries, there is the sympathetic trunk and the superior cervical ganglion. All right, now let's switch gears and look at the esophagus, which is a muscular tube that connects the pharynx to the stomach. The esophagus is continuous with the laryngopharynx at the pharyngo-esophageal junction, which appears externally as a constriction produced by the cricopharyngeal part of the inferior pharyngeal constrictor muscle, and is the narrowest part of the esophagus, and is also known as the superior esophageal sphincter. The esophagus can be divided into three parts: the upper part, which consists of striated muscle, the lower part, made up of smooth muscle, and the middle part, consisting of a mixture of striated and smooth muscle. This means that the upper part of the esophagus is under voluntary control when we swallow, and the lower part is under autonomic control and initiates reflexive peristalsis when food is present, with the middle part being under a mix of voluntary and autonomic control. Now, the only part of the esophagus that is found in the neck is the upper part, called the cervical esophagus, which begins immediately posterior to the inferior border of the cricoid cartilage at the level of the C6 vertebra, where it enters the superior mediastinum via the superior thoracic aperture, becoming the thoracic esophagus. It lies between the trachea, to which is attached by loose connective tissue, and the cervical vertebral column. On the right side, there's the right lobe of the thyroid gland, as well as the right carotid sheath with its contents. And on the left side, there's the left lobe of the thyroid gland, the left carotid sheath, and also the thoracic duct, which adheres to the left side of the esophagus. At the root of the neck, the cervical esophagus comes into contact with the cervical pleura. Now, the arterial supply of the cervical esophagus is provided by branches of the inferior thyroid artery that anastomose with each other across the midline. Tributaries of the inferior thyroid veins drain the cervical esophagus. The innervation of the upper half of the esophagus is provided by somatic motor and sensory fibers, and the innervation of the lower half is provided by parasympathetic, sympathetic, and visceral sensory fibers. All right, as a quick recap, the pharynx extends from the cranial base to the inferior border of the cricoid cartilage anteriorly and the inferior border of the C6 vertebra posteriorly. It's located posterior to the nasal and oral cavities, and it extends inferiorly past the larynx, where it's continuous with the esophagus. The interior of the pharynx is divided into three parts: the nasopharynx, which is located posterior to the nasal cavity and superior to the soft palate; the oropharynx, which is located posterior to the oral cavity and extends from the soft palate to the superior border of the epiglottis; and the laryngopharynx, which is located posterior to the larynx, extending from the superior border of the epiglottis to the inferior border of the cricoid cartilage. The pharynx has two layers of muscles: an external circular layer composed of superior, middle, and inferior pharyngeal constrictors, and an internal longitudinal layer composed of the palatopharyngeus, stylopharyngeus, and salpingopharyngeus. The esophagus begins in the neck, where it's continuous with the laryngopharynx at the pharyngo-esophageal junction. The upper part is composed of striated muscle, the middle part is mixed, and the lower part is composed of smooth muscle.
The neck is the anatomical region between the base of the cranium superiorly and the clavicles inferiorly, and it joins the head to the trunk and limbs, serving as a major conduit for structures passing between them. The skeleton of the neck is formed by the cervical vertebrae, the hyoid bone, and the manubrium of the sternum, which are part of the axial skeleton, as well as the clavicles, which are part of the appendicular skeleton. Alright, so let's start with the cervical vertebrae, of which there are 7. These are the smallest vertebrae, and they form the cervical region of the vertebral column, enclosing the cervical spinal cord and meninges. Cervical vertebrae can be typical or atypical, and when it comes to the cervical column, the typical vertebrae are C3, C4, C5, and C6, while the atypical vertebrae are C1, C2, and C7. Okay, so all typical vertebrae have a vertebral body, a vertebral arch, and 7 individual processes. The vertebral body is situated anteriorly, and it's small and longer from side to side than antero-posteriorly. It has a concave superior surface and a convex inferior surface. These surfaces are the vertebral end plates, which help form the intervertebral joints together with the intervertebral discs and the adjacent vertebra. On the superior surface, there's an elevated superolateral margin called the uncus of the body, or the uncinate process. Next, there's the vertebral arch, which is located posterior to the vertebral body and is formed by 2 pedicles and 2 laminae. The pedicles are short, thick processes that project posteriorly from the vertebral body to meet the laminae, which are 2 broad, flat plates of bone that unite in the midline and complete the vertebral arch. The vertebral arch and the posterior surface of the vertebral body form the walls of the vertebral foramen, through which the spinal cord and its meninges pass. The vertebral foramen is rather large and, in the cervical region, triangular. Next up, superior and inferior to the pedicles, there are shallow depressions called vertebral notches. When the vertebrae articulate, these notches align with those on the neighboring vertebrae and form the openings of the intervertebral foramina, through which the spinal nerves emerge from the vertebral column. Finally, each typical vertebra has 7 processes that arise from the vertebral arch: a spinous process, 2 transverse processes, and 4 articular processes. So, the spinous process is located in the middle and projects posteriorly and usually inferiorly, typically overlapping the vertebra below. Interestingly enough, even though spinous processes are typically unified, meaning they end with a single tip, C3 to C6 spinous processes can also be bifid, typically in individuals of European heritage. Next, there are the 2 transverse processes, which project laterally and end as 2 projections called the anterior and posterior tubercle, which serve as muscle attachment points. The transverse processes of C1 to C6 also have a hole called the foramen transversarium, which serves for the passage of the vertebral arteries and veins. The foramen transversarium of C7 only houses small accessory veins, and it can be absent. Finally, the 4 articular processes, 2 superior and 2 inferior, arise from the junctions of the pedicles and laminae, and each has an articular surface or facet. The superior facets are oriented supero-posteriorly, and the inferior facets are directed infero-anteriorly. The superior and inferior articular processes articulate with the corresponding processes of the neighboring vertebrae to form the zygapophyseal joints. These joints determine the type of movement permitted and restricted between the neighboring vertebrae of each region, and also they keep the vertebrae aligned, preventing one vertebra from translating or slipping anteriorly on the vertebra below. Now let's switch gears and look at the atypical vertebrae, called so because they have different characteristics from the other vertebrae. First, vertebra C1, also called the atlas, is a ring-shaped bone that doesn't have a body or a spinous process. So, instead of a body, it has paired lateral masses that serve as a body and sustain the weight of the globe-like cranium, just like Atlas of Greek mythology, who bore the weight of the world on his shoulders. The transverse processes of the atlas arise from the lateral masses, so these processes are placed more laterally than those of the inferior vertebrae. This makes the atlas the widest of the cervical vertebrae. Now, the lateral masses have two superior, concave, kidney-shaped articular surfaces. These surfaces articulate with two large cranial protuberances on either side of the foramen magnum on the occipital bone to form the atlanto-occipital joint. The movements permitted in this joint are flexion and extension. Think about headbanging at a rock concert, and a small amount of lateral flexion and rotation, like when you look over your shoulder. The anterior and posterior arches extend between the lateral masses and form a complete ring. The anterior arch has an anterior tubercle and a facet for the dens, and the posterior arch has a posterior tubercle and a groove for the vertebral artery. On the anterior arch, there's a tubercle for the transverse ligament. The transverse ligament extends from one lateral mass to the other lateral mass on the atlas, passing between the spinal cord and the dens, which is a part of the C2 vertebra. Speaking of which, the C2 vertebra is also called the axis because it has a blunt, tooth-like dens or odontoid process. The dens projects superiorly and articulates with the posterior surface of the anterior arch of the atlas, and it's held in place by the transverse ligament. Next, C2 also has two large, flat-bearing surfaces called the superior articular facets on which the atlas rotates. It also has inferior articular processes and transverse processes, similar to the other cervical vertebrae. Now, C2 also has a large bifid spinous process that can be felt deep in the nuchal groove, which is the superficial vertical groove at the back of the neck. Now, the atlas and the axis join together and form the atlanto-axial joint, which is a complex joint made up of three synovial joints, one median joint and two lateral joints. The lateral joints consist of the lateral masses of atlas and axis, while the median joint is between the posterior surface of the anterior arch of atlas and the front of the odontoid process. The primary movement in this joint is rotation, or moving the head side to side, known as the no movement. Finally, C7 is also called the vertebra prominens because it has a long spinous process. You can actually palpate it superficially as you run your finger and press along the midline of the back of your neck. Let's take a quick break and try to identify the features of a typical vertebra, as well as identify the three atypical vertebrae based on their features. Now, let's see what the hyoid bone is all about. This one is a U-shaped, mobile bone located in the anterior part of the neck at the level of C3 vertebra. Specifically, it sits in the angle between the mandible and the thyroid cartilage. Interestingly enough, the hyoid doesn't articulate with any other bone. Instead, it's suspended from muscles connecting it to multiple structures, including the mandible, styloid process, and thyroid cartilage. The hyoid bone is connected to the styloid processes of the temporal bones by the stylohyoid ligaments and is firmly bound to the thyroid cartilage. Functionally, it serves as an attachment for anterior neck muscles and a prop to keep the airway open. Now, the hyoid bone itself consists of a body and greater and lesser horns. The body of the hyoid is located in the middle. It faces anteriorly and has an anterior convex surface which projects antero-superiorly, and a posterior concave surface which projects postero-inferiorly. So far, so good. Now, each end of the body is united with a greater horn that projects postero-superiorly and laterally from the body. And near the junction between the body and the greater horn on either side, there's a lesser horn, which projects supero-posteriorly toward the styloid process. The lesser horns are connected with the body by fibrous tissue, and sometimes to the greater horn by a synovial joint. Alright, as a quick recap, the skeleton of the neck is formed by the cervical region of the vertebral column and the hyoid bone. The cervical column has 7 vertebrae, which are both typical and atypical. A typical vertebra has a vertebral body, a vertebral arch, and 7 processes, and are represented by 4 of the cervical vertebrae, C3, C4, C5, and C6. An atypical vertebra has some unique characteristics that help differentiate it from a typical vertebra, and the cervical column has 3 of these vertebrae, C1 or atlas, C2 or axis, and C7. C1 articulates with the 2 large cranial protuberances of the occipital bone to form the atlanto-occipital joint, permitting flexion and extension. C1 and C2 articulate to form the atlanto-axial joint, permitting rotation or moving the head side to side, known as the no movement. Finally, there is the hyoid bone, having no bony articulations and serving as an attachment point for many muscles in the neck.
The neck has both superficial and deep structures. But before you stick your neck out and try to guess what the deep structures are, we'll just tell you. The deep structures consist of paravertebral muscles and the viscera extending through the superior thoracic aperture at the root of the neck. When looking at the root of the neck specifically, it joins the neck and thorax, and acts like a passageway for neurovascular structures going from the thorax to the head or upper limb, and vice versa. It's located on the cervical side of the superior thoracic aperture, which is formed laterally by the first pair of ribs and their costal cartilages, anteriorly by the manubrium of the sternum, and posteriorly by the body of T1 vertebra. The root of the neck contains neurovascular structures, like the brachiocephalic trunk and the subclavian arteries, as well as veins such as the external and anterior jugular veins, and the subclavian vein, and then nerves such as the vagus nerve, phrenic nerves, and the sympathetic trunks. Let's look at the arteries first. The brachiocephalic trunk is the largest branch of the aorta, which arises in the midline from the beginning of the arch of the aorta, posterior to the sternal manubrium. It's covered anteriorly by the right sternohyoid and sternothyroid muscles, and passes superolaterally to the right and bifurcates posterior to the sternoclavicular joint into the right common carotid artery and right subclavian artery. Now the right and left subclavian arteries supply each upper limb and also send branches to the neck and brain. Now, while the right subclavian artery arises from the brachiocephalic trunk, the left subclavian artery arises from the arc of the aorta directly, about 1 centimeter distal to the origin of the left common carotid artery. Although the 2 subclavian arteries have different origins, they have the same course in the neck. So they start posterior to the sternoclavicular joints on either side, and they ascend through the superior thoracic aperture and enter the root of the neck. Here they arch superolaterally, reaching an apex as they pass posterior to the anterior scalene muscles. They then begin to descend until they disappear posterior to the middle of the clavicles. When they cross the outer margin of the first ribs, their name changes and they become the axillary arteries. Now, each subclavian artery has 3 parts, which are described relative to the anterior scalene muscle. So, the first part is medial to the anterior scalene. The second part is posterior to the muscle, and the third part is lateral to the anterior scalene. The first part of the artery gives 3 branches: the vertebral artery, the internal thoracic artery, and the thyrocervical trunk. The second part gives the costocervical trunk, and the third part gives the dorsal scapular artery. The vertebral artery ascends in the neck and passes through the foramina transversaria of C1 through C6 vertebrae. Then, it enters the cranial cavity through the foramen magnum, also known as that big hole in the occipital bone to its friends. Here, the vertebral artery supplies the medulla and the spinal cord, parts of the cerebellum, and the dura of the posterior cranial fossa. The internal thoracic artery arises from the antero-inferior aspect of the first part of the subclavian artery and passes inferomedially into the thorax, and goes on to supply the anterior thoracic wall. The thyrocervical trunk arises from the antero-superior aspect of the first part of the subclavian artery, near the medial border of the anterior scalene muscle, and it has 4 branches: the inferior thyroid artery, the suprascapular artery, the ascending cervical artery, and the transverse cervical artery. The inferior thyroid artery supplies the larynx, trachea, esophagus, thyroid and parathyroid glands, and the adjacent muscles. The ascending cervical artery supplies the lateral muscles of the upper neck. The suprascapular artery passes through the posterior triangle, then posterior to the clavicle, to supply the supraspinatus and infraspinatus. Finally, the cervicodorsal trunk, or the transverse cervical artery, passes through the posterior triangle and supplies the trapezius muscle. Next, the costocervical trunk arises from the posterior aspect of the second part of the subclavian artery, behind the anterior scalene, and it passes posterior-superiorly to divide into the superior intercostal and deep cervical arteries, which supply the first 2 intercostal spaces and the posterior deep cervical muscles. Finally, the dorsal scapular artery typically branches off the third part of the subclavian artery. However, sometimes the dorsal scapular artery arises as a deep branch of the transverse cervical artery. Regardless of its origin, it supplies the levator scapulae and rhomboids. So far, so good. Let's take a quick break and try to recognize the branches of the subclavian artery. Next, let's take a look at the veins in the root of the neck. There are 2 large veins that terminate in the root of the neck: the external jugular vein, which mostly drains blood from the scalp and face, and the anterior jugular vein, which arises near the hyoid from the union of the superficial submandibular veins, and drains blood from the anterior aspect of the neck. The anterior jugular vein descends into the root of the neck, where it drains into the external jugular vein, or the subclavian vein. Now, the subclavian vein is a continuation of the axillary vein that begins at the lateral border of the first rib. It passes over the first rib anterior to the scalene tubercle, and parallel to the subclavian artery, from which is separated by the anterior scalene muscle. The subclavian vein has only one tributary, which is the external jugular vein, and ends when it joins with the internal jugular vein to form the brachiocephalic vein. This union is called either the right or left venous angle, which is located posterior to the medial end of the clavicle. The left venous angle is where the thoracic duct drains lymph, and the right venous angle is where the right lymphatic duct drains lymph. Finally, there are 3 major pairs of nerves in the root of the neck: vagus nerves, phrenic nerves, and sympathetic trunks. Now, the vagus nerves exit from the jugular foramen, and then each nerve passes inferiorly in the neck within the posterior part of the carotid sheath in the angle between the internal jugular vein and the common carotid artery. The right vagus nerve passes anterior to the first part of the subclavian artery, and posterior to the brachiocephalic vein, and to the sternoclavicular joint to enter the thorax. The left vagus nerve descends between the left common carotid artery and the left subclavian artery, and posterior to the sternoclavicular joint to enter the thorax. In the inferior part of the neck, each vagus nerve gives a recurrent laryngeal nerve, which have essentially the same distribution. However, they loop around different structures and at different levels on the two sides. So the right recurrent laryngeal nerve loops inferior to the right subclavian artery at the level of T1 to T2 vertebrae. The left recurrent laryngeal nerve loops inferior to the arch of the aorta at the level of T4 to T5 vertebrae. After looping, both nerves ascend superiorly to the posterior-medial aspect of the thyroid gland, where they ascend in the tracheoesophageal groove, supplying both trachea and esophagus, as well as the intrinsic muscles of the larynx, except the cricothyroid. The phrenic nerves are formed at the lateral borders of the anterior scalene muscles, mainly from the C4 nerve with contributions from C3 and C5 nerves. Each phrenic nerve forms at the superior part of the lateral border of the anterior scalene muscle at the level of the superior border of the thyroid cartilage, and they descend obliquely with the internal jugular vein across the anterior scalene, deep to the prevertebral layer of deep cervical fascia, and the transverse cervical and suprascapular arteries. The left phrenic nerve crosses anterior to the first part of the subclavian artery, and the right phrenic nerve lies on the anterior scalene muscle and crosses anterior to the second part of the subclavian artery. On both sides, they run posterior to the subclavian vein and anterior to the internal thoracic artery as it enters the thorax. These nerves provide the sole motor supply to the diaphragm, as well as sensation to its central part. They also supply the mediastinal pleura and pericardium. Finally, the root of the neck contains the cervical portion of the sympathetic trunks, which are located anterolateral to the vertebral column and extend superiorly to the level of C1 vertebrae, or the cranial base. They include 3 cervical sympathetic ganglia, superior, middle, and inferior, which receive presynaptic fibers transmitted to the trunk by the superior thoracic spinal nerves inferiorly and their associated white rami communicantes. Then, they ascend through the sympathetic trunk to these 3 ganglia. In the cervical sympathetic ganglia, the thoracic presynaptic fibers synapse with the postsynaptic neuron, which then send fibers and sympathetic innervation to the cervical spinal nerves via gray rami communicantes, to the thoracic viscera via cardiopulmonary splanchnic nerves, and to the head and viscera of the neck via cephalic arterial branches, such as the external carotid and vertebral arteries. Now, the superior cervical ganglion is located at the level of C1 and C2 vertebrae and sends sympathetic innervation to the cranial cavity via branches traveling with arteries such as the carotids. The middle cervical ganglion is the smallest of the 3 ganglia and is occasionally absent. When it's present, it's located on the anterior aspect of the inferior thyroid artery at the level of the cricoid cartilage and the transverse process of C6 vertebra. It sends sympathetic innervation to organs like the heart and the thyroid gland. Finally, the inferior cervical ganglion fuses with the first thoracic ganglion in 80% of individuals and forms the cervicothoracic ganglion, or stellate ganglion, which is a star-shaped ganglion located anterior to the transverse process of C7 vertebra, just superior to the neck of the first rib on each side, and posterior to the origin of the vertebral artery. This sends sympathetic innervation to C7 and C8 spinal nerves via gray rami communicantes, as well as nerves to the heart and trachea. Okay, so before we wrap up, let's take a quick break and see if you can recognize the 3 major pairs of nerves and the root of the neck. Alright, as a quick recap. The root of the neck is a junctional area between the neck and thorax, and is the gateway for neurovascular structures going from the thorax to the head or upper limb, and vice versa. It's formed laterally by the first pair of ribs and their costal cartilages, anteriorly by the manubrium of the sternum, and posteriorly by the body of T1 vertebra. Arteries passing through the root of the neck are the brachiocephalic trunk and subclavian arteries. Each subclavian artery has three parts, where the first part of the artery gives three branches: the vertebral artery, the internal thoracic artery, and the thyrocervical trunk. The second part of the artery gives the costocervical trunk, and the third part of the artery typically gives the dorsal scapular artery. Veins in the root of the neck are represented by the external and anterior jugular veins, which eventually drain into the subclavian vein. The subclavian vein then combines with the internal jugular vein to form the brachiocephalic vein and the venous angles where the lymphatic drainage occurs. Major nerves in the root of the neck are the vagus nerves and its branching of the recurrent laryngeal nerve, phrenic nerves supplying the diaphragm, and sympathetic trunks, which include superior, middle, and inferior cervical ganglia to distribute sympathetic innervation to the cranium, neck, thorax, and upper limb. The neck is the anatomical region between the base of the cranium superiorly and the clavicles inferiorly, and it joins the head to the trunk and limbs, serving as a major conduit for structures passing between them. The neck contains superficial structures located in the anterior and posterior triangles, and deep structures, like the cervical viscera and the prevertebral muscles. Now, the prevertebral muscles are deep to the prevertebral layer of the deep cervical fascia, and they are divided into the anterior prevertebral muscles and the lateral prevertebral muscles. The anterior prevertebral muscles are located directly posterior to the retropharyngeal space and medial to the neurovascular plane of the cervical plexus, brachial plexus, and subclavian artery. They're represented by longus colli, longus capitis, rectus capitis anterior, and anterior scalene muscles. Now, the longus colli originates from the bodies of C5 to T3 vertebrae and the transverse processes of C3 to C5 vertebrae. It inserts onto the anterior tubercle of the C1 vertebra, the bodies of the C2 to C4 vertebrae, and the transverse processes of C3 to C6 vertebrae. It's innervated by the anterior rami of C2 to C6 spinal nerves. When it contracts bilaterally, it produces flexion of the neck, and when it contracts unilaterally, it produces rotation to the opposite side. Next, there's the longus capitis, which originates from the anterior tubercles of the transverse processes of C3 through C6, and inserts onto the basilar part of the occipital bone. It's innervated by the anterior rami of spinal nerve C1 through C3, and its contraction results in flexion of the head at the atlanto-occipital joint. Next, the rectus capitis anterior originates from the anterior surface of the lateral mass of the atlas, which is the first cervical vertebra, and inserts onto the base of the cranium anterior to the occipital condyles. It's innervated by branches from the loop between C1 and C2 spinal nerves, and its contraction also results in flexion of the head at the atlanto-occipital joint. Finally, the anterior scalene muscle originates from the anterior tubercles of the transverse processes of the C3 to C6 vertebrae and inserts onto the first rib. It's innervated by the anterior rami of spinal nerve C4 to C6, and it functions to elevate the first rib during forced inspiration, and when the rib is fixed, bilateral contraction produces flexion of the neck and unilateral contraction produces lateral flexion of the neck. Next up are the lateral prevertebral muscles, located posterior to the neurovascular plane of the cervical and brachial plexuses and subclavian artery. These are the rectus capitis lateralis, middle and posterior scalene muscles, levator scapulae, and splenius capitis. Rectus capitis lateralis originates from the transverse processes of the atlas and inserts onto the jugular process of the occipital bone. It's innervated by branches from the loop between C1 and C2 spinal nerves, and when it contracts, it stabilizes and flexes the atlanto-occipital joint. Next, the middle scalene muscle originates from the posterior tubercles of transverse processes of C3 to C7 vertebrae, while the insertion is on the superior surface of the first rib, posterior to the groove for the subclavian artery. It's innervated by anterior rami of the C3 to C7 spinal nerves. As with the anterior scalene, it elevates the first rib during forced inspiration, and when the rib is fixed, bilateral contraction produces flexion of the neck, and unilateral contraction produces lateral flexion of the neck. The posterior scalene muscle originates from the posterior tubercles of the transverse processes of C5 to C7 and inserts inferiorly on the extended border of the second rib. It's innervated by the anterior rami of spinal nerve C7 and C8. The posterior scalene elevates the second rib during forced inspiration, and, just like the other scalenes, when the rib is fixed, bilateral contraction produces flexion of the neck, and unilateral contraction produces lateral flexion of the neck. The anterior scalene, middle scalene, and posterior scalene are considered accessory muscles of inspiration because during deep inhalations, they lift the ribs they are attached to, which contributes to increasing the intrathoracic volume. Next, the levator scapulae originates from the posterior tubercles of the transverse processes of the C1 to C4 vertebrae and inserts onto the superior part of the medial border of the scapula. It's innervated by the anterior rami of C3 and C4, and the dorsal scapular nerve, which mainly derives from C5, as well as potentially C4. It elevates the scapula and produces downward rotation of the scapula, which causes the glenoid cavity to tilt inferiorly. The splenius capitis originates from the inferior half of the nuchal ligament and the spinous processes of C7 to T4. It inserts onto the mastoid process of the temporal bone and the lateral third of the superior nuchal line. It's innervated by the posterior rami of the middle cervical spinal nerves, and it produces lateral flexion and rotation of the head to the same side when it acts unilaterally, as well as extension of the head and neck when acting bilaterally. Okay, time for a quick break. Try to identify the anterior and lateral prevertebral muscles. Okay, as a quick recap, the deep structures of the neck include the prevertebral muscles, which are divided into anterior prevertebral muscles, represented by longus colli, longus capitis, rectus capitis anterior, and anterior scalene muscles, and the lateral prevertebral muscles, which are represented by rectus capitis lateralis, the middle scalene muscle, posterior scalene muscle, levator scapulae, and splenius capitis. The structures found in the neck are surrounded by a layer of subcutaneous tissue called the superficial fascia, while there are also layers of deep cervical fascia, which distribute the structures in the neck into different compartments. These fascial layers create different anatomical spaces in the neck and dictate where an infection may spread if it starts in one of these compartments. So let's take a look at the different fascial layers of the neck. You can think of fascia as a pair of thin stockings made of connective tissue that support and bind together different parts of the body, including the neck. Now, the neck actually has two pairs of stockings on top of each other: the superficial fascia, which sits right underneath our skin, and the deep fascia, which is deep to or beneath the superficial fascia, and it surrounds muscles and viscera, organizing them into compartments. Okay, so the superficial cervical fascia, or the cervical subcutaneous tissue, is a layer of fatty connective tissue that lies between the skin and the most superficial layer of deep cervical fascia. This fascia is usually thinner than in other regions, especially anteriorly, and it contains cutaneous nerves, blood and lymphatic vessels, superficial lymph nodes, and variable amounts of fat. Anterolaterally, it contains the platysma, which is a thin sheet of muscle that covers the anterolateral portion of the neck. Inferiorly, the platysma attaches to the deep fascia that covers the superior parts of pectoralis major and deltoid muscles, with its fibers moving supromedially over the clavicle and attaching superiorly to the inferior border of the mandible and skin and subcutaneous tissues of the lower face. The anterior borders of the two platysma muscles join together over the chin and blend with the facial muscles, but inferiorly, the fibers remain separated, leaving a gap anterior to the larynx and trachea. Deep to the platysma, there are the main cutaneous nerves of the neck and the external jugular vein, which descends from the angle of the mandible to the middle of the clavicle. The platysma is supplied by the cervical branch of the facial nerve, or cranial nerve 7, and it's involved in facial expression. Acting from its superior attachment, it tenses the skin, producing vertical skin ridges, and releasing pressure on the superficial veins. This action is often used when people shave their necks or ease a tight collar. Acting from its inferior attachment, it depresses the lower jaw, and also draws down the lower lip and angle of the mouth in the expression of sadness or fright. Moving on, the deep cervical fascia consists of 3 fascial layers, or sheaths, called the investing, pretracheal, and prevertebral fascia, which serve to support the cervical viscera, muscles, vessels, and lymph nodes. The deep cervical fascia also wraps around the common carotid arteries, internal jugular veins, and vagus nerves to form the carotid sheath. These fascial layers form natural cleavage planes through which tissues may be separated during surgery, and they limit the spread of abscesses that can result from infections. Also, they allow the structures in the neck to move and pass over one another without difficulty, such as when swallowing or turning the head and neck. Okay, so let's begin with the investing layer of the deep cervical fascia, which is the most superficial deep fascial layer. This layer surrounds the entire neck deep to the skin and subcutaneous tissue, investing the trapezius and sternocleidomastoid muscles. Superiorly, it attaches to the superior nuchal lines of the occipital bone, the mastoid processes of the temporal bones, the zygomatic arches, the inferior border of the mandible, the hyoid bone, and the spinous processes of the cervical vertebrae. Just inferior to its attachment to the mandible, the investing layer splits to enclose the submandibular gland, and posterior to the mandible, it splits to form the fibrous capsule of the parotid gland, both of which are salivary glands. Inferiorly, the investing layer attaches to the manubrium of the sternum, clavicles, and acromions, and spines of the scapulae. Posteriorly, the investing layer continues with the periosteum that covers the C7 spinous process, and with the nuchal ligament, which is a triangular membrane that forms a median septum between the muscles of the 2 sides of the neck. Inferiorly, between the sternal heads of the sternocleidomastoid muscle and just superior to the manubrium, the investing layer remains divided into 2 layers to enclose the sternocleidomastoid muscle. One layer attaches to the anterior and the other to the posterior surface of the manubrium to form a space called the suprasternal space. Here the inferior ends of the anterior jugular veins, the jugular venous arch, some fat, and a few deep lymph nodes can be found. Now, let's move on to the pretracheal layer of deep cervical fascia, which is located in the anterior part of the neck and extends from the hyoid bone into the thorax, where it blends with the fibrous pericardium that covers the heart. This layer has 2 parts, a thin muscular part that encloses the infrahyoid muscles, and a visceral part that encloses the thyroid gland, trachea, and esophagus. The visceral part extends posteriorly and superiorly to blend with the bucopharyngeal fascia of the pharynx. Laterally, the pretracheal layer blends with the carotid sheath. Superior to the hyoid, the pretracheal layer forms a pulley, or trochlea, through which passes the intermediate tendon of the digastric muscle, suspending the hyoid. Inferiorly, the pretracheal layer communicates freely with the mediastinum of the thorax. If an infection between the muscular part of the pretracheal fascia and the visceral part of the pretracheal fascia were to arise, then it could spread anterior to the pericardium into the thoracic cavity. Next, the prevertebral layer of the deep cervical fascia forms a tubular sheath for the vertebral column and the muscles associated with it, such as longus colli and longus capitis anteriorly, the scalenes laterally, and the deep cervical muscles posteriorly. The cervical part of the sympathetic trunk is also embedded in the prevertebral fascial layer. The prevertebral layer is fixed superiorly to the cranial base, and inferiorly it ends by blending with the endothoracic fascia and fusing with the anterior longitudinal ligament centrally, at approximately the T3 vertebra. Laterally, the prevertebral fascia extends as the axillary sheath which surrounds the axillary vessels and brachial plexus. Time for a break. Let's pause and see if you can identify the superficial cervical fascia, as well as the deep cervical fascia with all of its layers. Okay, now just a few words on the carotid sheath and the retropharyngeal space, which are important spaces located in the neck. The carotid sheath is a tube of fascia that extends from the cranial base to the root of the neck, and contains the common and internal carotid arteries, internal jugular vein, vagus nerve, some deep cervical lymph nodes, carotid sinus nerve, and sympathetic nerve fibers. This sheath blends anteriorly with the investing and pretracheal layers of deep cervical fascia, and posteriorly with the prevertebral layer of deep cervical fascia. Along with the pretracheal fascia, the carotid sheath communicates freely with the mediastinum inferiorly. Finally, the retropharyngeal space is the largest interfascial space in the neck. It's a potential space, consisting of loose connective tissue between the visceral part of the prevertebral fascia and the bucopharyngeal fascia surrounding the pharynx superficially, and it allows the pharynx, esophagus, larynx, and trachea to move relative to the vertebral column during swallowing. The retropharyngeal space is closed by the cranial base superiorly and by the carotid sheath laterally, but remains open inferiorly, communicating with the thorax and the superior mediastinum. The retropharyngeal space is further divided into a true retropharyngeal space and danger space by a thin sheath of fascia called the alar fascia, which attaches along the midline of the bucopharyngeal fascia from the cranium to the level of C7, extending laterally to the carotid sheaths. The true retropharyngeal space is located anterior to the danger space and extends from the base of the skull to where the alar fascia fuses with the bucopharyngeal fascia. The danger space extends more inferiorly, communicating with the posterior mediastinum until the level of the diaphragm. Alright, as a quick recap. The neck has two pairs of stockings on top of each other. The superficial fascia, which sits right underneath our skin, and the deep fascia, which is deep to or beneath the superficial fascia, and it surrounds muscles and viscera, organizing them into compartments. The superficial cervical fascia, or the cervical subcutaneous tissue, is a layer of fatty connective tissue which contains cutaneous nerves, blood and lymphatic vessels, superficial lymph nodes, and variable amounts of fat, and anterolaterally it contains a platysma, which is a thin sheet of muscle involved in facial expression. The deep cervical fascia supports the cervical viscera, muscles, vessels, and lymph nodes, and consists of three fascial layers, or sheaths: investing, pretracheal, and prevertebral, and also wraps around the common carotid arteries, internal jugular veins, and vagus nerves to form the carotid sheath. The investing layer encloses the trapezius muscle, sternocleidomastoid muscle, and the submandibular and parotid glands. The pretracheal layer encloses the infrahyoid muscles, thyroid gland, trachea and esophagus, and the prevertebral layer encloses the vertebral column and its associated muscles. The pretracheal fascia and the carotid sheath freely communicate with the mediastinum inferiorly, and the space between the muscular and visceral layers of pretracheal fascia communicates with the thoracic cavity anterior to the pericardium. There's also the retropharyngeal space, found between the visceral part of the prevertebral fascia and the bucopharyngeal fascia, with part of this space communicating with the superior and posterior mediastina.
The neck is the anatomical region between the base of the cranium superiorly and the clavicles inferiorly, joining the head to the trunk and limbs and serving as a major conduit for structures passing between them. In the neck, there are superficial structures located in the anterior and posterior triangles and deep structures, including the cervical viscera and prevertebral muscles. Now, the neck is divided into the anterior and posterior triangles mainly by the borders of the sternocleidomastoid, or SCM, and trapezius muscles. Now, the SCM is a broad, strap-like muscle which has a sternal and a clavicular head. The sternal head is rounded, and its inferior portion originates from the manubrium of the sternum, while the clavicular head is thick, and its inferior portion originates from the superior surface of the medial third of the clavicle. The two heads of the SCM are separated inferiorly, forming a superficially visible space called the lesser supraclavicular fossa, which looks like a small triangular depression. Superiorly, the two heads of SCM join as they go toward the cranium and insert on the mastoid process of the temporal bone and the superior nuchal line of the occipital bone. The posterior border of this muscle forms the anterior boundary of the posterior triangle. When the SCM contracts, it produces movement at either the craniovertebral joints or the cervical intervertebral joints, or at both. So, unilateral contraction of SCM leads to lateral flexion of the neck to the same side, and also rotates the head so your face is turning superiorly toward the opposite side. Bilateral contraction of SCM can lead to three different movements: extension of the neck at the atlanto-occipital joint, which makes the chin rise, flexion of the neck, which makes the chin approach the manubrium, and extension of the superior cervical vertebrae, combined with flexion of the inferior vertebrae, which makes the chin thrust forward with head kept level. Additionally, bilateral contraction of SCM with the head and neck fixed can lead to elevation of the clavicles and manubrium, and thus the elevation of the anterior ribs. This action makes the SCMs act as accessory muscles of respiration as they assist in lifting the sternum anterosuperiorly, which is referred to as the pump handle movement of the thoracic wall. Finally, the SCM is innervated by the spinal accessory nerve, or cranial nerve 11, as well as fibers from C2 and C3. And then there's the trapezius, which is a large triangular muscle that covers the posterolateral aspect of the neck and thorax. It originates from the medial third of the superior nuchal line, external occipital protuberance, nuchal ligament, and the spinous processes of the C7 to T12 vertebrae. It inserts onto the lateral third of the clavicle, acromion, and spine of the scapula. The anterior border of the trapezius forms the posterior boundary of the posterior triangle. Now, the trapezius also causes many different actions. Its superior fibers elevate the scapula, its middle fibers retract the scapula, and its inferior fibers depress the scapula. The superior and inferior fibers can also work together to produce upward rotation of the scapula, causing the glenoid cavity to tilt superiorly. And finally, when the shoulders are fixed, bilateral contraction of the superior fibers extends the neck, while unilateral contraction causes lateral flexion to the same side. Just like the SCM, the trapezius is innervated by the spinal accessory nerve and also by spinal nerves C2 and C3. Now, the posterior triangle, like any respectable triangle, has three sides, called boundaries. The anterior boundary is formed by the posterior border of the SCM, the posterior boundary is formed by the anterior border of the trapezius, and the inferior boundary is formed by the middle third of the clavicle between the trapezius and the SCM. The posterior triangle has an apex where the SCM and trapezius meet on the superior nuchal line of the occipital bone, a deep boundary, or floor, formed by several prevertebral muscles covered by the prevertebral layer of deep cervical fascia, and a superficial boundary, or roof, formed by the investing layer of deep cervical fascia. The floor of the posterior triangle is formed primarily by four muscles: the splenius capitis, levator scapulae, middle scalene, and posterior scalene. Okay, so the splenius capitis originates on the inferior half of the nuchal ligament and the spinous processes of C7 to T4. It inserts onto the mastoid process of the temporal bone and the lateral third of the superior nuchal line. Levator scapulae originates from the posterior tubercles of the transverse processes of the C1 to C4 vertebrae and inserts onto the superior part of the medial border of the scapula. The middle scalene is the largest and longest of the three scalene muscles, and it originates from the posterior tubercles of the transverse processes of C3 to C7 and inserts onto the superior surface of the first rib, posterior to the subclavian groove. The posterior scalene muscle is the smallest and most deeply seated of the scalene muscles. It originates from the posterior tubercles of the transverse processes of C5 to C7 and inserts onto the external border of the second rib. There's also the anterior scalene muscle, which lies deep to the sternocleidomastoid muscle. This means it's usually hidden, but sometimes it can be visualized in the inferomedial portion of the posterior triangle. The anterior scalene originates from the anterior tubercles of the transverse processes of the C3 to C6 vertebrae and inserts onto the scalene tubercle on the first rib. Let's take a quick break and try to identify the muscles that form the boundaries and floor of the posterior triangle. Now, the posterior triangle is further divided by the inferior belly of the omohyoid into two other triangles: the occipital triangle, located superiorly, and the much smaller omoclavicular triangle, located inferiorly. The occipital triangle contains the occipital artery at its apex and also the spinal accessory nerve. The omoclavicular triangle, also called the subclavian triangle, can be seen on the surface of the neck as the supraclavicular fossa, and it's bounded by the inferior belly of the omohyoid posterosuperiorly, the posterior border of SCM anteriorly, and the middle third of the clavicle inferiorly. The inferior part of the external jugular vein crosses the triangle superficially, and deep to it is the investing layer of deep cervical fascia. Now, let's talk about the subclavian artery, which arches medial to the clavicle and passes between the anterior and middle scalene muscles. In the inferior part of the omoclavicular triangle, the third and final part of the subclavian artery can be visualized. It is the longest and most superficial part of the subclavian artery, beginning at the lateral border of the anterior scalene muscle and ending at the lateral border of the first rib, where it continues as the axillary artery. It lies deep in the inferior part of the omoclavicular triangle, where it is in contact with the first rib and is situated posterosuperior to the subclavian vein. This third part of the artery lies directly anterior to the inferior trunk of the brachial plexus. Its pulsations can be felt by applying deep pressure in the omoclavicular triangle. The posterior triangle also contains the lateral branches of the thyrocervical trunk and part of the occipital artery. The thyrocervical trunk is a branch of the subclavian artery, and its lateral branches are the suprascapular artery and the cervicodorsal trunk. The suprascapular artery travels inferolaterally across the anterior scalene muscle and phrenic nerve, running inferior to the cervicodorsal trunk. It crosses the third part of the subclavian artery and the cords of the brachial plexus, and then passes posterior to the clavicle to supply muscles on the posterior aspect of the scapula. The cervicodorsal trunk, also known as the transverse cervical artery, runs superficially and laterally across the phrenic nerve and anterior scalene muscle and splits in two other branches, the superficial cervical artery and dorsal scapular artery. These branches either cross or pass through the trunks of the brachial plexus and give branches to their vasa nervorum, which are blood vessels that supply nerves. The superficial cervical artery then runs deep to the trapezius, and the dorsal scapular artery runs deep to the levator scapulae and rhomboids, supplying both. Finally, the occipital artery is a branch of the external carotid artery, and it enters the posterior triangle at its apex and climbs over the head to supply the posterior half of the scalp. Now, the veins in the posterior triangle include the external jugular vein, which begins near the angle of the mandible by the union between the posterior division of the retromandibular vein and the posterior auricular vein. It crosses the SCM obliquely, deep to the platysma, and enters the antero-inferior part of the posterior triangle. Then it pierces the investing layer of deep cervical fascia at the posterior border of SCM. Then the external jugular vein descends to the inferior part of the omoclavicular triangle and drains into the subclavian vein. Superior to the clavicle, it receives the cervicodorsal, suprascapular, and anterior jugular veins, and through all its tributaries it drains most of the scalp and side of the face. Finally, the nerves in the posterior triangle are the spinal accessory nerve, or cranial nerve 11, as well as the brachial plexus and the cervical plexus. The spinal accessory nerve runs deep to the SCM and innervates it before entering the posterior triangle at or inferior to the junction of the superior and middle thirds of the posterior border of SCM. Then it passes postero-inferiorly, within or deep to the investing layer of deep cervical fascia, and runs on the levator scapulae, from which it is separated by the prevertebral layer of deep cervical fascia. Finally, it disappears deep to the anterior border of the trapezius and innervates it. Next, the brachial plexus is formed by the anterior rami of the spinal nerves C5, C6, C7, C8, and T1, and it emerges between the anterior and middle scalene muscles to descend inferolaterally through the posterior triangle. The plexus then passes between the first rib, clavicle, and superior border of the scapula to enter the axilla, where it provides innervation for most of the upper limb. From the superior trunk of the brachial plexus arises the suprascapular nerve, which runs laterally across the posterior triangle to supply the supraspinatus and infraspinatus muscles on the posterior aspect of the scapula. Finally, the cervical plexus can also be found in the posterior triangle, including its superficial branches, which are cutaneous nerves that emerge at the posterior border of the SCM. The roots of the cervical plexus arise from the anterior rami of the spinal nerves C1, C2, C3, and C4. Alright, as a quick recap, the posterior triangle is a major region of the neck which is bounded anteriorly by the posterior border of the SCM, posteriorly by the anterior border of the trapezius, and inferiorly by the middle third of the clavicle between the trapezius and the SCM. It has a roof formed by the investing layer of deep cervical fascia and a floor formed by the muscles splenius capitis, levator scapulae, middle scalene, posterior scalene, and occasionally a portion of anterior scalene, which are covered by the prevertebral layer of deep cervical fascia. The posterior triangle is further divided by the inferior belly of omohyoid into two other triangles: the occipital triangle located superiorly, and the omoclavicular triangle located inferiorly. The posterior triangle includes arteries such as the suprascapular artery, cervicodorsal trunk, the third part of the subclavian artery, and part of the occipital artery, veins such as the external jugular vein, and nerves such as spinal accessory nerve, brachial plexus, and cervical plexus. The neck is the anatomical region between the base of the cranium superiorly and the clavicles inferiorly, and it joins the head to the trunk and limbs, serving as a major conduit for structures passing between them. The neck is divided in two major triangles, anterior and posterior, based mainly on the borders of the sternocleidomastoid, or SCM, and trapezius muscles, as well as other muscular and bony structures found in the neck. These regions provide a clear location regarding the structures, injuries, or pathologies involving the neck. Now, the anterior triangle, like any respectable triangle, has three sides, called boundaries. The anterior boundary is formed by the median line of the neck, the posterior boundary is formed by the anterior border of the sternocleidomastoid muscle, or SCM for short, and the superior boundary is formed by the inferior border of the mandible. The triangle has a superficial boundary, or a roof, formed by subcutaneous tissue containing the platysma, a deep boundary or floor formed by the pharynx, larynx, and thyroid gland, and an apex located at the jugular notch in the manubrium. And if that wasn't enough, the anterior triangle is further subdivided by the omohyoid and digastric muscles into four smaller triangles: submental, submandibular, carotid, and muscular. The submental triangle sits right below the chin and contains several small submental lymph nodes and small veins that unite to form the anterior jugular vein. Inferiorly, the submental triangle is bounded by the hyoid body and laterally by the right and left anterior bellies of the digastric muscles. The floor is formed by the two mylohyoid muscles which meet in a median fibrous raphe, the apex is located at the mandibular symphysis, and the base is formed by the hyoid bone. Next, the submandibular triangle contains the submandibular gland, submandibular lymph nodes, cranial nerve 12, which is the hypoglossal nerve, mylohyoid nerve, and parts of the facial artery and facial vein. In addition, in 20% of individuals, the marginal mandibular branch of the facial nerve extends below the inferior border of the mandible into the submandibular triangle. The submandibular triangle is bounded superiorly by the inferior border of the mandible, antero-inferiorly by the anterior belly of the digastric muscle, and postero-inferiorly by the posterior belly of the digastric muscle. Its floor is formed by the mylohyoid and hyoglossus muscles, and its roof by the investing layer of deep cervical fascia. The hypoglossal nerve enters the submandibular triangle by passing deep to the posterior belly of the digastric muscle and deep to the mylohyoid muscle within the submandibular triangle. It provides motor innervation to the intrinsic and extrinsic muscles of the tongue. Finally, there are also some spinal nerves in the mix. C1 fibers travel with the hypoglossal nerve and give off the thyrohyoid branch for the thyrohyoid muscle. Then there's the superior root of the ansa cervicalis, which is composed of fibers from C1 and C2. The superior root of the ansa cervicalis unites with the inferior root of the ansa cervicalis, which derives from spinal nerves C2 and C3. These superior and inferior roots form a loop which gives off branches to supply the omohyoid, sternothyroid, and sternohyoid muscles. Next, the carotid triangle is bound inferomedially by the superior belly of the omohyoid muscle, superiorly by the posterior belly of the digastric muscle, and inferolaterally by the anterior border of the SCM. The carotid triangle contains blood vessels such as the common carotid artery with its branches, the external carotid artery and some of its branches, the internal jugular vein and its tributaries, and also nerves like branches of the vagus nerve, the hypoglossal nerve and superior root of ansa cervicalis, the spinal accessory nerve, and branches of the cervical plexus and viscera such as the thyroid gland, larynx, pharynx, and deep cervical lymph nodes. The neurovascular structures in the carotid triangle are surrounded by the carotid sheath. In the carotid sheath, the carotid arteries lie medially, the internal jugular vein lies laterally, and the vagus nerve lies posteriorly. Superiorly, the common carotid artery is replaced by the internal carotid artery, and on the anterolateral aspect of the sheath you can find the ansa cervicalis. Let's take a quick break and see if you can identify all of the different triangles in this image. Speaking of carotids, there are two common carotid arteries. The right common carotid artery, which begins at the bifurcation of the brachiocephalic trunk, forming it and the right subclavian artery, and the left common carotid artery, which begins at the arch of the aorta and ascends into the neck. Each common carotid artery splits into the internal and external carotid arteries at the upper border of the thyroid cartilage. The internal carotid arteries give off no named branches in the neck, and they enter the cranium through the carotid canals in the petrous parts of the temporal bones. Here they become the main arteries for the brain and structures in the orbits. The proximal part of each internal carotid artery contains the carotid sinus, which is a baroreceptor that reacts to changes in arterial blood pressure and is innervated by the glossopharyngeal nerve through the carotid sinus nerve and also by the vagus nerve. The carotid body is located in a septum on the deep side of the bifurcation of the common carotid artery in close relation with the carotid sinus. It is also innervated primarily by the carotid sinus nerve, a branch of the glossopharyngeal nerve, and it acts as a chemoreceptor that monitors the level of oxygen in the blood. This means that when there are low levels of oxygen, that sends a signal to the brain to increase the respiration rate. The external carotid arteries supply most structures external to the cranium, and they run posterior-superiorly to the region between the neck of the mandible and the lobule of the auricle, where they split in two terminal branches: the maxillary artery, which has three major branches that supply numerous structures, and the superficial temporal artery, which enters the temporal fossa and supplies regions of the scalp. Before its termination, it gives off 6 arteries: the superior thyroid artery, ascending pharyngeal artery, lingual artery, facial artery, occipital artery, and posterior auricular artery. A good mnemonic to remember the branches of the external carotid artery in order from which branch is first is "some anatomists like freaking out poor medical students," where the first 4 branches arise from the anterior aspect and the last 4 from the posterior aspect. So first, there's the superior thyroid artery, which runs deep into the infrahyoid muscles to supply the thyroid gland. It also supplies the infrahyoid muscles and SCM and gives a branch called the superior laryngeal artery, which supplies the larynx. Second, there's the ascending pharyngeal artery, which ascends to the pharynx, giving branches to the pharynx, prevertebral muscles, middle ear, and cranial meninges. Third, the lingual artery runs deep to the hypoglossal nerve, the stylohyoid muscle, and the posterior belly of the digastric muscle, and gives branches to the posterior tongue. Then it turns superiorly at the anterior border of the hyoglossus muscle and splits into 2 branches, the deep lingual artery and the sublingual artery. Fourth, the facial artery gives rise to the ascending palatine artery and the tonsillar artery. Then it passes obliquely beneath the digastric and stylohyoid muscles and the angle of the mandible, and it gives rise to the submental artery to the floor of the mouth and hooks around the middle of the inferior border of the mandible to enter the face. It is the major arterial supply of the face, giving rise to several branches on its route towards the medial angle of the eye. Fifth, the occipital artery arises from the posterior aspect and ends in the posterior part of the scalp, where it splits into numerous branches. The posterior auricular artery arises from the posterior aspect, and it ascends posteriorly between the external acoustic meatus and mastoid process to supply the neighboring muscles, parotid gland, facial nerve, and structures in the temporal bone, auricle, and scalp. Finally, the 2 terminal branches, namely the maxillary artery and the superficial temporal artery, arise from the external carotid all the way up in the head. Now that we just learned about the major vessels in the neck, can you label all of the branches from the external carotid artery? Now let's switch gears and look at the internal jugular vein, or IJV, which is the largest vein in the neck. In fact, most veins in the anterior region are tributaries to it. It starts at the jugular foramen in the posterior cranial fossa as a direct continuation of the sigmoid sinus and descends laterally in the carotid sheath. The vein leaves the anterior cervical region by passing deep to the gap between the sternal and clavicular heads of the sternocleidomastoid muscle. Posterior to the sternal end of the clavicle, the internal jugular vein merges with the subclavian vein to form the brachiocephalic vein. The inferior end of the vein dilates to form the inferior bulb of the vein, which has a bicuspid valve that allows blood to flow toward the heart and prevent backflow into the vein. Tributaries of IJV are the inferior petrosal sinus, facial, lingual, pharyngeal, superior, and middle thyroid veins, which drains blood from the brain, anterior face, cervical viscera, and deep muscles of the neck. And finally, there's the muscular triangle, or the omotracheal triangle, which is bounded superolaterally by the superior belly of the omohyoid muscle, inferolaterally by the anterior border of SCM, and medially by the median plane of the neck. This triangle contains the sternothyroid and sternohyoid muscles, as well as the thyroid and parathyroid glands. Now, muscles in the anterior triangle are represented by the hyoid muscles. These muscles steady or move the hyoid and larynx and are divided into suprahyoid and infrahyoid muscles. So, the suprahyoid muscles connect the hyoid to the cranium and includes 4 muscles: mylohyoid, geniohyoid, stylohyoid, and digastric. The mylohyoid muscle arises from the mylohyoid line of the mandible and attaches to the mylohyoid raphe and the body of the hyoid. It's innervated by the nerve to mylohyoid, a branch of the trigeminal nerve, and elevates the hyoid, the floor of the mouth, and the tongue during speaking and swallowing. The geniohyoid muscles are immediately superior to the mylohyoid muscles. They arise from the inferior mental spine of the mandible and attach to the hyoid body. It's innervated by C1 via the hypoglossal nerve and pulls the hyoid anterosuperiorly, and it also shortens the floor of the mouth and widens the pharynx. The stylohyoid muscle arises from the styloid process of the temporal bone, and it attaches to the hyoid body. It's innervated by the stylohyoid branch of the facial nerve, and it elevates and retracts the hyoid, and so it elongates the floor of the mouth, which comes in handy during swallowing. The digastric muscle translates as 2 bellies, so there's the anterior belly, which arises from digastric fossa of the mandible, and the posterior belly, which arises from the mastoid notch of the temporal bone. The 2 bellies are united by an intermediate tendon and attached to the body and greater horn of the hyoid bone. The anterior belly is innervated by the nerve to the mylohyoid, and the posterior belly is innervated by the digastric branch of the facial nerve. Its role is to work with the infrahyoid muscles to depress the mandible against resistance, and it elevates and steadies the hyoid during swallowing and speaking. Then there are the infrahyoid muscles, which anchor the hyoid inferiorly and depress it. These 4 muscles are arranged in 2 planes: a superficial plane, made up of the sternohyoid and omohyoid, and a deep plane, composed of the sternothyroid and thyrohyoid muscles. And a pro tip is that the names of these muscles indicate where they originate and insert. So the sternohyoid muscle arises from the manubrium of the sternum and the medial end of the clavicle and inserts on the hyoid body. It's innervated by C1 to C3 by a branch of the ansa cervicalis, and it depresses the hyoid after elevation during swallowing. Next, there's the omohyoid muscle, which has 2 bellies, a superior and an inferior one, which are united by an intermediate tendon. With this muscle, omo refers to the scapula, so it arises from the superior border of the scapula near the suprascapular notch, and it attaches to the inferior border of hyoid. It's innervated by C1 to C3 by a branch of ansa cervicalis and depresses, retracts, and steadies the hyoid. Then there's the sternothyroid muscle, which arises from the posterior surface of the manubrium, and it attaches to the oblique line of thyroid cartilage. It's innervated by C2 and C3 by a branch of ansa cervicalis and depresses the hyoid and larynx. The thyrohyoid muscle arises from the oblique line of thyroid cartilage, and it attaches to the inferior border of the body and greater horn of the hyoid. It's innervated by C1 via hypoglossal nerve and depresses the hyoid and elevates the larynx. Finally, let's try to label the hyoid muscles on this image. Alright, as a quick recap, the anterior triangle has the following boundaries: an anterior boundary formed by the median line of the neck, a posterior boundary formed by the anterior border of the SCM, and a superior boundary formed by the inferior border of the mandible. Furthermore, the anterior triangle is subdivided by the omohyoid and digastric muscles into 4 smaller triangles: submental, submandibular, carotid, and muscular. The submental triangle contains several small submental lymph nodes and small veins that unite to form the anterior jugular vein. The submandibular triangle contains the submandibular gland, submandibular lymph nodes, hypoglossal nerve, mylohyoid nerve, and parts of the facial artery and facial vein. The carotid triangle contains the common carotid artery with its branches, the internal jugular vein and its tributaries, the vagus nerve, the external carotid artery and some of its branches, the hypoglossal nerve and superior root of ansa cervicalis, the spinal accessory nerve, the thyroid gland, larynx, pharynx, deep cervical lymph nodes, and branches of the cervical plexus. The muscular triangle contains the infrahyoid muscles and the thyroid and parathyroid glands. The common carotid artery splits into the internal carotid artery, which doesn't give any branches for the neck, and the external carotid artery, which has numerous branches such as superior thyroid artery, ascending pharyngeal artery, lingual artery, facial artery, occipital artery, and posterior auricular artery, and 2 terminal branches, maxillary artery and superficial temporal artery. Muscles of the anterior triangle are represented by the suprahyoid and infrahyoid muscles. The suprahyoid muscles are represented by mylohyoid, geniohyoid, stylohyoid, and digastric muscles, and the infrahyoid muscles are represented by sternohyoid, omohyoid, sternothyroid, and thyrohyoid muscles.
The cervical plexus is an important plexus of nerves which provide innervation to the head and neck. This plexus is located anteromedial to the levator scapulae and middle scalene muscles and deep to the sternocleidomastoid, or SCM. Now the anterior rami of the spinal nerves C1, C2, C3, and C4 form the roots of the cervical plexus, which is an irregular series of nerve loops and the branches that arise from these loops. Each participating ramus, except the first, splits into ascending and descending branches, which unite with branches from neighboring spinal nerves to form the loops. The superficial branches of the plexus, which initially pass posteriorly, are cutaneous or sensory branches, which innervate the skin, and the deep branches of the plexus, which includes the roots of the phrenic nerve and the ansa cervicalis, pass anteromedially and are motor branches which innervate the muscles of the neck. The cutaneous branches of the cervical plexus emerge around the middle of the posterior border of the SCM, and they supply the skin of the neck, superolateral thoracic wall, shoulder, and scalp between the auricle and the external occipital protuberance. Now let's look at the 4 cutaneous nerves that innervate these areas. There are 3 nerves branching from the C2 and C3 loop. The lesser occipital nerve, which contains fibers from C2, supplies the skin of the neck and scalp posterior superior to the auricle. The great auricular nerve contains fibers from both C2 and C3 and ascends across the SCM to the inferior pole of the parotid gland, where it divides to innervate the skin over and the sheath surrounding the parotid gland, the mastoid process, the posterior inferior part of the auricle, and an area of skin that extends from the angle of the mandible to the mastoid process. There is also the transverse cervical nerve, which also contains fibers from C2 and C3. It curves around the middle of the posterior border of the SCM, passing anteriorly and horizontally across it, deep to the external jugular vein and the platysma to innervate the skin covering the anterior triangle. The branches of the cervical plexus that arise from the C3 and C4 nerve loop are the supraclavicular nerves, which contain fibers from C3 and C4 and emerge as a common trunk deep to the SCM. These branches send smaller branches to the skin of the neck that cross the clavicle and supply the skin over the shoulder. And finally, there are the motor branches of the cervical plexus that include the ansa cervicalis and the phrenic nerves, which arise from the loops of the cervical plexus, as well as branches that arise from the roots of the brachial plexus, such as dorsal scapular nerve, mainly from C5, but sometimes also from C4, which innervates the levator scapulae and rhomboid muscles, and the long thoracic nerve from C5 to C7, which innervates the serratus anterior muscle. The ansa cervicalis is a loop formed by the union of the superior root of the ansa cervicalis, which is composed of fibers from C1 and C2, and can be seen briefly joining the hypoglossal nerve, and the inferior root of the ansa cervicalis, composed of fibers from C2 and C3. The ansa cervicalis innervates the infrahyoid muscles, specifically the omohyoid, sternothyroid, and sternohyoid, but not the thyrohyoid, which is innervated by a motor nerve which derives solely from the C1 fibers that travel along or hitchhike with the hypoglossal nerve, before descending as the nerve to the thyrohyoid. Another motor nerve which derives from the C1 fibers that travel with the hypoglossal nerve is the nerve to the geniohyoid, which innervates, the geniohyoid muscle. The phrenic nerve originates mainly from the C4 nerve with contributions from the C3 and C5 nerves. It contains motor, sensory, and sympathetic nerve fibers. Each phrenic nerve forms at the superior part of the lateral border of the anterior scalene muscle at the level of the superior border of the thyroid cartilage, and descends obliquely with the internal jugular vein across the anterior scalene. The phrenic nerves provide the sole motor supply to the diaphragm. You can remember this fact and the nerve roots that form the phrenic nerve by the mnemonic C3, 4, and 5 keep the diaphragm alive. The phrenic nerves also provide sensory innervation to the central part of the diaphragm, as well as the mediastinal pleurae and pericardium. Before we hit the recap, let's take a quick break and try to identify the sensory and motor branches of the cervical plexus. All right, let's do a quick recap. The cervical plexus forms from the anterior rami of spinal nerves C1, C2, C3, and C4, and has two types of branches, cutaneous and motor branches. The cutaneous branches are represented by the lesser occipital nerve, great auricular nerve, transverse cervical nerve, and supraclavicular nerves, and the motor branches are represented by the ansa cervicalis, phrenic nerves, nerve to the thyrohyoid, and nerve to the geniohyoid.